Hello everybody, my name is Etienne Cavaignac. I'm very happy to be with you today for this first practical course orthopedic webinar about ACL revision, state of the art in 2023. My colleagues today are Philipp Niemeyer from Germany, Munich, and Charles Pioger, MD and future PhD from Paris. The program today will be why do ACL reconstruction fail? Then we will speak about diagnostic, bone grafting, one or two stage procedure, anterolateral stabilization, and osteotomy consecutive or concomitant to the ACL revision. I would like first of all to thank BIOBank for the kind support. Everything is possible thanks to BIOBank, and we are very happy to work with you all day long in the OR and for this webinar particularly. The first speaker is Philipp Niemeyer from Munich. Philipp, why do ACL reconstruction fail?
Yeah, thank you very much for the kind introduction, and hello from Munich in Germany. It's a great pleasure to join you. Thanks for having me. And I really appreciate that I'm also able to give the introduction for this really compact 45 minutes, which will be about all aspects about ACL revision surgery. And the reason for failure is actually what you have to ask in every single case when you evaluate a patient with a failed ACL reconstruction. And interestingly, there is definitely a high rate of re-ruptures, which is giving in literature between 4 and 15%. In mean, there are some publications reporting even higher re-rupture rates. So this topic is definitely relevant. And in the majority of the cases, actually, the patient will probably tell that he has sort of a trauma suffering, and probably he will be suggesting somehow that this is a real traumatic re-rupture he is talking about. And this is basically what my talk will be about. You really have to challenge this traumatic re-rupture idea. And the closer you will be looking on this individual case, probably the lower the number of real traumatic re-ruptures get. And this is why I personally also think that these numbers given in a publication almost 15 years ago are probably not true anymore. So I personally consider the amount of real traumatic re-ruptures being much lower than 25%. And to be honest, probably also the number of technical issues associated with the re-rupture is lower than 30% in our days, since we really have learned about reasons and really have learned about primary ACL reconstruction and avoid technical issues. Nevertheless, there is definitely technical issues and reasons for failure. The most common probably is malpositioning of the tunnels. Here you see a really anterior positioning of the tibial tunnel. And there definitely is also biological failure, but biological failure is something mystic in my personal opinion, because you really, in the majority of the cases, you cannot really prove an efficient ingrowth of the graft. You cannot really prove graft rejection or insufficient ligamentation of the graft, which are common explanations for potential biological failure. But what you really can identify is other categories, such as osseous alignment, which I will be talking about later on. And if you are really interested in getting into detail, there has been a really nice review been published actually last week in the Effort Journal by a group from the ESCA, which actually really categorizes very good these different aspects of reasons for failure of your primary ACL reconstruction. And in this review, and also in my personal opinion, the most common mechanism of failure is probably a biomechanical reason, and it's chronic overload. This can be related to malpositioning of the tunnels, as I said before, but what you really should also focus is peripheral instabilities. So we have really learned much about anterolateral instability in recent years, and there will also be a talk tonight about that issue. But once you have a significant anterolateral rotational instability, the forces applied to your ACL graft, which will significantly increase And this overload is definitely something which can cause failure. So anterolateral has become popular, but in my personal opinion, anteromedial is definitely as relevant as the anterolateral instability. And this is something we have learned about recently. So also really closely look on the medial side. Once you have an insufficiency of the MCL or the anteromedial bundles of the MCL, this also puts higher loads on your ACL graft and might be a really relevant factor for failure. And this is also something which is really important. I have already mentioned. You also should look on the bony alignment. And this topic really came into also scientific literature in recent years. The most prominent aspect of bony malalignment is probably the increase of the tibial slope. I will be covering this topic later on, but we know definitely this is associated with graft failure. Last point is also the role of the patient. We know some subgroup of patients which are at higher risk for graft failure. The most popular is definitely the higher re-rupture rate in women, which is really a problem, especially in professional athletes. For instance, soccer players. There have been multiple reasons being discussed recently, which are associated with this observation, but it's definitely really a problem. Other problems are hyperlux patients. This is really a challenge in my personal practice as well, which I'm somehow afraid of because they are associated with higher re-rupture rates. And the most relevant in my eyes is young persons, adolescents, because we really know these subgroup of ACL injured people or children and adolescents are really at high risk, and we really have to think about concepts to avoid these re-ruptures in this really exposed subgroups of patients. And the problem even becomes bigger when all these parameters are combined. This is a study which has become really popular in recent years, which is actually a study which demonstrates a really high failure rate, especially in adolescents, active athletes, in combination with the posterior lateral slope. So I'm really convinced that you really need to avoid all these risk factors as best as possible. Nevertheless, there will be a certain risk for re-rupture, and how to deal with this re-ruptures will be topic of today's webinar. So I'm really excited to listen to the subsequent talks, and thank you very much at that point.
Thank you, Philipp. So Charles, what diagnostic is mandatory in case of ACL revision and re-rupture?
Thank you, Etienne, and thank you, the PCO committee, for this kind invitation. So in this talk, I will try to give some important messages for anyone, any surgeon who has to manage with ACL revision, and particularly what evaluation and what diagnostic is mandatory before considering such a surgery. So first, we need to collect any patient-specific information due to their role as predisposing factor to ACL failure, and to perform an anteroposterior meticulous physical examination with anteroposterior laxity test, with classical manual test, Lachman, anterior drawer, and we do evaluate, because its role is crucial in the revision setting, we do evaluate the rotatory laxity with the pivot shift test in a awake patient during medical consultation, but also in operating room. And we continue our thorough physical examination with coronal laxity testing because missing concomitant injuries such as MCL or posterolateral corner can contribute to ACL graft failure. In the same way, we need to check if there is a significant passive hyperextension and a misalignment. Very important consideration is do not forget the muscle. Recently, the new entity well described by Bertrand Sonricotet is the arthrogenic muscle inhibition. We need to check the presence of arthrogenic muscle inhibition. We have now a classification, we have treatment option, and this preoperative neuromuscular assessment is mandatory before any knee surgery, and of course before revision surgery. Another crucial part of the preoperative planning is the radiographic evaluation, and the first line test is the weight-bearing monopodal X-rays with AP and lateral view. And in cases of misalignment, a long leg standing XR is needed. Some parameters are fundamental to analyze, for sure the tunnel position and the enlargement, winding, but also the posterior tibial slope, and we can discuss correction if it's greater than 12 degrees, the anterior tibial translation, and the coronal limb misalignment with a cutoff greater than 5 degrees or a unicompartmental osteoarthritis. What about the tunnel placement analysis? The recent consensus by the SK has agreed on two radiographic methods to define a misplaced femoral and tibial tunnel, with the Bernard and Hertel method for the femoral tunnel, and for the tibial side, the Stobley method. So you can check the tunnel placement on XR. And what about the additional imaging? MRI is, of course, mandatory before revision because it gives critical information about associated intra-articular lesion like meniscal status, hardware position, and gives indirect signs of ACL graft rupture like PCL buckling, anterior tibial translation, or the presence of bone bruises. But the most important is the meniscal status, because meniscal status predicts graft failure, and we can easily miss such meniscal lesion like a ramp tear or posterolateral root tear. So MRI is the first step to control that before a meticulous arthroscopic evaluation. CT scan is not routinely used in our practice, but it can be justified for surgeon considering a two-stage approach, or if the tunnel winding or placement is unclear on XR. So in conclusion, the management of revision is now a common challenge. We need an accurate preoperative planning for successful revision, and this requires to collect patient-specific information, a meticulous physical examination, and a comprehensive analysis of preoperative imaging. Thank you.
Thank you, Charles. Let's go now to how to do bone grafting. This is my talk. How I do that. Let's first of all start with the indication, and you will see that's very clear. As a member of the Santi group, I do 100% of my ACL revision in one stage. My only indication for bone grafting is a one-stage concomitant procedure, bone grafting and ACL, and I do that only in case of not good enough tunnel to be useful, not bad enough to not interfere, because I'm afraid about the overlapping of the semi-anatomic tunnel. We published that article in Arthroscopy a few years ago. What are the specifications of the device you need to do this bone grafting concomitant to an ACL revision? First of all, it has to be easy to do. It has to be quick to allow a one-stage procedure. It has to be mechanically strong enough to eliminate the overlap risk. That's why I decided to start with the device designed by BIOBank, which is an allograft bone plug, 28 mm long, and the diameter from 9 to 14 that allows you to feel also big, let's say, big osteolysis in tunnel. What do we have to focus on? 3 points. First of all, you have to identify the previous tunnel. A complete debridement of the tunnel is mandatory, and then after you have to fill the tunnel with the allograft, and it's really quite easy. What about the materials needed? In order to identify the previous tunnel, you just need the car wire and sometimes the guide. Why the guide? Because sometimes you have a corticalization of the tunnel and it's not possible to find the aperture, so you need a guide to find it. So as you can see, this is only your classic ACL tools, nothing more. For the complete debridement, this is also a classic ACL tool. You just need the drill because you have already found the tunnel with the car wire and just have to clean everything. Don't forget every time, as you can see here, to control arthroscopically that everything inside the tunnel has been removed. And then the filling. The filling needs this specific tool. The bone plug is cannulated, And so you can put it inside the tunnel as close as possible to the aperture, the emergence intra-articulary, to be to fill the gap at the beginning of the tunnel, which is the most difficult part to reach. It has to be done with arthroscopic control. Let me show you with two examples. The first one is a one-stage ACL revision. As you can see here, the tibial tunnel is very too anterior, but is not wrong enough to be completely missed. The femoral tunnel is completely wrong in that case. So the tunnel is not wrong enough to be avoided, but is not good enough to be used again. So I decided to graft it and to do another one close. First step is to identify the tunnel. It was quite easy here because the tibial aperture was still open, and I put the pin at the good place. The cal wire. Then after I go for the classic ACL tunnel with the jig. Once again, the way to identify the tunnel. Then I will drill it to clean everything and to remove all the old ligament inside. It's a progressive dealing, increasing side by side to be sure to remove everything. As you can see here, it has to be completely clear. And then is the filling. The filling of the tunnel is really quite easy. You see the plug is here. You just have to put it on the wire and to put inside. You can feel the contact with the bone, and you go as close as possible to the tibial aperture, as you can see here. And then after, your complicated ACL revision becomes a very simple one, because you drill the tibia, and I drill the complete tibia without any problem. And then graft passage. I will show you the technique I use for the revision then after. As you can see here, there is the new tunnel and the old one. And with the post-op CT, you can control the position of the femur here, it's quite normal. And with the tibia, you will see there the new position, the new tunnel, and close to it, very close, the old tunnel and the allograft inside. Here, you have the complete view with the CT scan. Let me just show you this case of a PCL revision, which is not so frequent, but you will see how strong the device is. The first step is the same. First of all, the tunnel identification. It's quite easy with a PCL revision. Then I had to debride the tunnel with increased size of the drill, as to have full contact and to remove all the cortical aspects. And then after, you control that everything is removed, and you just have to put the bone plug inside in the same way. And you will see how strong the device is, because now I will do another tunnel. The aperture is very close. It's an inside-out technique, as you can see there. The first one was not good enough for me, so I decided to grab the first one and to do immediately after the new tunnel. It was very difficult to drill and look the results once the tunnel is drilling. It's very difficult to identify where is the allograft and where is the normal bone. And you will see with the CT scan right now that you can create a new position very close to the first one. And believe me, it was very difficult to drill inside the device. So for me, it's clear. This is the choice of efficiency. As usual for me in the OR, you have to be easy, quick, and strong. This is the good choice. I think the device could be very helpful in this challenging situation in which the tunnel is not good enough to be used again. It's not bad enough to be completely forget. And don't forget the Congress, the new concept course in Toulouse next June. We have now some time for discussion for the first part. Philippe, could you hear me?
Yeah, perfectly. Thank you.
You know, I'm very. I appreciate a lot your talk and to be really open about the reason an ACL failed, because it is the first step of the way to treat a patient. We are not technicians, we are physicians, so we are here to understand the problem and to solve it, not only to put an ACL into a joint. So my point is about the biological aspect, because I think clearly that this is something sometimes, and let's say in the majority of the cases, completely lost, and it's really important, because if there is no incorporation of the graft, there is no future for the graft. So what's your opinion about this biological aspect? What's the way you have to evaluate this? For example, do you still do surgeries with smokers, or it's something you decide to avoid?
Yeah, so my point was basically that you should not really trust in the patient when he tells you that was a traumatic rupture. And also this discussion of biological failure is something which I personally believe that we believed for a long time that we cannot influence this biology, and maybe believed just do another ACL revision surgery and hoped it will be better. So what I really think important is that we have to exclude any kind of infection. So if we have a patient with persistent complaints in terms of effusion, I would definitely also harvest biopsies for microbiological analysis. But this biological ingrowth problem, this is something I personally cannot diagnose 100%. It's a more subjective impression sometimes. In these cases, I would be even more careful in order to have a perfect debridement, as you actually mentioned in the revision setup. But it's nothing you really can prove 100%. And this is why I don't feel 100% comfortable with that.
And what about the smokers?
I personally do surgeries in smokers because I also do believe that an unstable joint in a smoker is definitely a problem. But you definitely have to talk about that with the patients, and it definitely influences outcome. And if he's able to avoid or to reduce, that's definitely something beneficial for the outcome of the revision surgery, no matter. Yeah.
Charles, do you do surgery on smokers?
Yes, I do, because yes, but I advise them to stop or to reduce the consumption. But yes, if you leave their knee unstable, I think the risk to have a new lesion, a new intercuticular lesion, is worse if you wait.
Concerning the diagnostic, you mentioned the AMI to evaluate previous to the surgery. Does it mean that if the patient doesn't have a full control of the vastus medialis, you will not go for surgery?
Yeah. For this case, it's not the case for smokers, but yes, if there is a persistent AMI, that's why I postpone, I delay the reconstruction, because the rehabilitation is not the same if before surgery you have a vastus medialis with no good contraction. So you need to have a full extension with the good vastus medialis before considering any surgery.
You need 2 points. You need full extension and full control of vastus medialis.
Yeah.
Okay. If you have any question, don't hesitate to use the questionnaire online. I've got one from Mark Schutz from Austria. The question was about the way to fill a cyst if you have a cylindric bone graft. This device for BIOBank, you can be used as a plug, but you can also have, let's say, chips and chisel that you can fill inside the cyst. So this is really something really easy to do. And there is it was the same question about the bone plugs and okay. Philipp, any comments for this first part, or do we go for the second part right now?
We can definitely proceed. Maybe a short question to you, Etienne. When you're doing these bone grafts, are you using any antibiotics in these, or do you add any antibiotics into in the revision cases?
I don't add any antibiotics into the allograft in the bone plug, but I use vancomycin wrapping around my graft in every cases. I mean, revision or primary in every case, but nothing special with the bone plug. I just put it in to transform my difficult case in a very small one. This is the antibiotics for the graft only. There is one question from the app. Charles, I think it's for you. How to evaluate the control of the vastus medialis?
Yes. So I advise to check the paper from Santi and from Bertrand Sandricotet's team. There is a very nice video on VGSM. You need to check the control and the relief of the vastus medialis. You need to contract. You put your finger just above the patella and you check a real good contraction. But you can remark in many cases, it's the patient is unable to contract the vastus medialis. So, but it's difficult to explain like that. So the main
point, I think, to control that, it's just to analyze the patella, as you said. The patella has to move. The order is to ask the patient to put the knees back and the patella up, and you will see the patella moving. And you have to be sure that there is no co-contraction. It means that you don't have a contraction of the hamstring and the vastus medialis at the same times.
And be careful, patient, not contract the rectus femoris. This is a mistake. Also, sometimes.
Just one short question before to start the other one. There is a question is about how do you address arthrofibrosis post-surgical procedure? In my practice in ortho and sports medicine, this is a stubborn one. Philipp, anything to say about arthrofibrosis?
Yeah, this is probably a topic of another webinar because it's real complex, and I really am afraid of early revision surgeries in these specific subgroup of patients. That is definitely a problem. Sometimes you have to do revision and arthrolysis in order to help these patients, but I try to avoid that. We do also apply oral medications in these patients using beta blockers and cortisone. This is something which has been established by Dr. Traut, which is a physician from the northern part of Germany. He's really focusing on arthrofibrosis, and we have somehow adapted that concept using these early medications, and actually have some good experiences with that, but it's a problematic topic, definitely.
Okay, we have to go for the second part. There is some more question we will discuss more for during the next stop. Please, Charles, tips and tricks in one-stage ACL revision.
Yeah, thank you. So in this talk, I'm going to give you some tips and tricks to perform a one-stage revision in every case. So what does the SCR consensus, the recent SCR consensus say? It gives us some absolute and relative indication with some concerns about the tunnel widening, especially greater than 12 millimeter, and also the convergence of semi-anatomic previous tunnel. So we have to perform a one-stage approach. And why? Because it limits morbidity of two procedures. We want to reduce the period of knee instability while awaiting the bone graft incorporation. And we want to reduce the associated economic cost. And the key to avoid this stage approach is definitively the outside-in femoral tunnel. It allows to solve two technical issues. First, a tunnel enlargement even greater than 12 millimeter, and a failed previous tunnel in semi-anatomic position. And why? Because the outside-in femoral tunnel is anatomically unconstrained. And as you can see on the illustration, when we drilled an outside-in femoral tunnel, you have very different trajectories. So no worries and no concern about convergence, about secure your graft fixation. Sometimes you can have a convergence at the aperture, but it's not a problem for graft fixation. In contrast, if you do an anteromedial or transtibial femoral tunnel, you are restricted. And in this case, you risk the convergence and conflict. So we choose some technical procedure. We choose BTB if a previous hamstring autograft was used, and hamstring with a combined procedure, ACL and allar reconstruction, if a previous BTB, QT, or fascial attack graft was used, and the CT scan was not routinely used. For BTB technique, we use the Chamba technique, recently published in arthroscopy by the team of Bertrandson-Ricotet. An historic technique from Lyon, and the tips are pretty the same than with hamstring. You need to use a specific footprint femoral guide to control and protect the posterior wall and to be perfectly anatomic, and you drill progressively, first with a 6 millimeter reamer, and after you can adjust and correct the tunnel position for the final drilling. And for fixation, there is a specificity with the Chamba technique because no need of under button or screw. This is a press fit fixation, so with a trapezoidal bone plug for femur. So no problem because no convergence, so no problem for fixation. And for tibia, we use an interference screw, and you can adjust the position because you have analyzed properly the previous tunnel. So this is an example. You can see the previous in-out femoral tunnel in a semi-anatomic position, a little bit to anterior. You can see the posterior wall. So we clean the notch and the posterior wall. And we drill anatomically with this specific femoral, outside-in femoral guide. We drill, and you can see we put, just after that, we put the scope into the outside-in tunnel. And here, you see the previous tunnel. So this is a complete different direction between the two tunnels, almost perpendicular. So no risk of convergence and no risk for your graft fixation. It is almost the same with the hamstring procedure. We use the combined ACL and ALL reconstruction procedure. So you use the same specific footprint femoral guide. You drill progressively again. The only difference it's about the fixation for femur. We use also, like for tibia, an interference screw, but no problem because a new trajectory for the femoral tunnel, and you can adjust the position. And no worry about the lateral extraarticular tenodesis, ALR reconstruction in this case, because we choose a soft fixation, so just suture. This is another case, this time with a misplaced femoral tunnel. So you can see again the specific guide and the outside-in drilling. And again, we adjust, we drill progressively to be perfectly anatomic. And you can see the former tunnel and the new one, and no convergence. So in conclusion, outside-in femoral drilling is a reliable and safe technique to avoid a two-stage approach. For sure, there is a learning curve because this is not the most commonly technique performed for a femoral tunnel, but in our experience, we never need for femoral bone grafting. Sometimes, but it's very rare, you need to bone grafting with osteolysis, big osteolysis, but you can do the bone grafting at the same time, like Etienne said, with BIOBank. And these two procedures allow us to do lateral extraarticular tenodesis, modified Lemaire in BTB case, and ALL reconstruction in hamstring case. Thank you.
So now, when to add an anterolateral stabilization and how? Why, first of all, why and when? I think just have a look on the last publication. This is at your right, the last paper from the consensus group of ESCA, and at your left, the last meta-analysis on the subject. There is no doubt. I mean, if you want to go and if you want to do an ACL revision, you have to add an anterolateral stabilization in every case. For me, it's completely clear, and the literature is clear. It's probably one of the only one point in which the literature is so clear. So in fact, the problem is not really the problem of the indication. The problem is a technical problem because of the tunnel, convergence of the tunnel. What's a tunnel convergence? This is the interference between an anterolateral tunnel and an ACL tunnel. And the risk is a potential damage of the ACL graft you have just done before. So it's really a big problem, and sometimes doing two tunnels in a small condyle, it's really a challenging procedure. How could we avoid this problem? If your choice is doing two tunnels, one for the anterolateral stabilization and one for the ACL, you have to control what you are doing. And to control, you have to put your scope inside the ACL tunnel and to drill the anterolateral tunnel under orthoscopic control. This is the only way from my side to control what you are going to do with a classic ACL and modified Lemaire. This is the way to do that. The graft harvesting is very classic. A strip of ITB pass underneath the lateral collateral ligament. No problem like that. You just have to be posterior and proximal to the lateral epicondyle, and then control everything you are doing with the scope inside the ACL tunnel. So you can see if there is any convergence when you are putting the wire. Then after, when you will drill, as you can show you, in my case, I drill always a 6 mm diameter tunnel for the Lemaire procedure. Then you can check everything. And don't forget at the end to check also the suture, because sometimes you can damage the suture and the tunnel is good, so it could be a pity also. And once everything is controlled, you just have to put your graft inside and to put a screw or whatever you want to fix the graft in the position, in your preferred position. But if you don't control, you don't know if you are in good position or no. The other option, which is my favorite option in case of revision, is a combined graft. I mean, it's an outside-in technique. Externally, the tunnel is a lateral tunnel disease, internally is ACL reconstruction. So if you do just one tunnel, there is no risk of convergence because there is just one tunnel, so no risk of conflict. This is a technique we published in arthroscopy. My choice is doing an ITB plus an allograft inside the ITB to reinforce the graft. The incision is a little bit longer than one for the modified Lemaire. You have to understand where is the ITB and to remove a graft. Thus, it's still attached at the Gerdy's tubercle, which is very important. This is the pediculate graft. It's really important. Once it's traversed, you just have to add the allograft to increase the size. Don't forget to open the posterior border of the vastus lateralis if you want to close the defect at the end. It's really a very nice tip and tricks, particularly if you have young, big, tight players. And then you add your allograft inside. You can use also the hamstring for the opposite side if you want. My choice is with allograft. And I reinforce this ITB with the allograft and with an internal brace inside. Then after classic revision, outside-in technique, I don't have the same guide. I put this in the anterolateral view. So it's an externally posterior and proximal to lateral epicondyle, internally at the place of the ACL, and then you put the drill inside. And then you do the drilling by increasing side by side. Normally I do 2 steps. The first one is 5 mm, and then after is the size of the graft, because I'm very happy to change a little bit the position if I need, more posterior, more proximal, more anterior. So if you do in 2 times, you can control that point also. This is the full tunnel at the end. And it is the same procedure for the tibia, and I will not discuss anymore if you do to have to use the same one or another one. And then you just have to pass your graft, and the graft is keep attached on the Gerdy's tubercle. And believe me, when you pull on it, you can feel immediately the stability because it's strong really soon. As soon as you do that for the rotation and the anterolateral translation. So just pull on the graft and you can feel that the knee is completely stable. You can add a screw on the femur, and you could add also a screw on the tibia. And if you are afraid by the fixation, you can also add a cortical device at the tibial aperture to be very sure of your fixation. I will show you an example right now. The screw and then a cortical device to be sure to have a secondary fixation close to the tibia aperture. Okay, why this graft is my first choice for the revision, ITB plus allograft? Because it's an outside-in technique and it solves many problems, as Charles already mentioned. It's a continuous extra intraarticular graft. This is the horseshoe effect. And really important for me, the biological aspect and the mechanical aspect of a pedicular graft, which is really important. Philipp, what's the role of osteotomy in ACL revision surgeries?
Yeah, thanks, Etienne, for this nice technique. I'm really amazed by this technique, and I will definitely try this also in my OR. So last talk from my side will be about osteotomy. So coming to the fact how bony alignments affect ACL stability with a specific aspect on revision surgery. And this is summarized by a nice review which has been published 5 years ago by Thomas Tischer from Erlangen. And he really demonstrated, and this was an eye-opener for me, he really demonstrated the relevance of bony alignment or osseous alignment And I personally believe this is a really important topic and definitely was one of my learnings in recent years. So once we're talking about bony deformities, which is associated with ACI failure, there's definitely many parameters open to discussion. I will be focusing on the tibial slope, but what I also want to mention is the varus deformity, and especially the dynamic varus deformity, which means the varus thrust. So once you observe anything like this associated with the varus deformity, actually it's a double varus deformity, a static bony varus in combination with the lateral instability. This is definitely something in which you have to address your bony alignment before you go for an ACL revision surgery, because otherwise you have a really high risk of graft failure. But as I mentioned before, tibial slope is definitely a topic which really became popular, and it became popular because it's of extraordinary relevance. And there's really good biomechanical data that show that once you have an increased tibial slope, the graft load or the graft force on the ACL significantly increases. That's vice versa for the PCL. And as you know, slope reduction is also used for a treatment of chronic PCL instabilities. But the relevance in the context of ACL rupture is definitely something which came into focus. And what I also want to mention is that we really have good clinical data on that. So I'm just, the connection from my pointer is just missing. Now it works again perfectly. So we really have biomechanical data. This is a finite element analysis, just to give you some numbers. And as you can see here, comparing a 0-degree posterior tibial slope, for instance, to a 10-degree tibial slope, more than doubles the graft load on the ACL. And this is what actually makes this topic relevant. There's also clinical data available. This is data on the influence of lateral tibial slope as a risk factor for primary ACL rupture, so no reconstructed knees. And this is also something which I already discussed with my patients. So actually everybody in our hospital is evaluated with a lateral view radiograph, also in primary cases. To be honest, I have not performed an osteotomy, a slope reduction osteotomy in primary cases yet, but I'm sure that I will consider once I sometimes experience a patient with a significant increased lateral slope in the future, because I am absolutely aware that this is a relevant risk factor. And this is really nicely shown by several studies, including this study, which is actually called the catastrophic effect of age and posterior slope, demonstrating that there's a high risk of graft failure in these patients with a slope of more than 12 degrees. What is also demonstrated in several biomechanical studies, this is just to give you some example or one example. This is the study by Florian Imhoff from Zurich, who really nicely demonstrated that a slope reduction surgically done by a closed wedge osteotomy is definitely able to reduce these increased graft forces. And this is why this concept definitely makes sense in my personal opinion. What I want to point out is that we are majorly talking about the lateral posterior slope. And this is something which is of relevance, because initially when we're talking about this increased tibial slope, for instance, in combination with the varus deformity, there definitely was the idea to correct the tibial slope in context with the varus deformity using a conventional medial open wedge technique. But what my personal thoughts on that topic is that you're probably more likely to change the medial slope instead of the lateral slope. And this is why I personally address all slope issues in my daily practice with an anterior approach instead of a medial approach. When talking about these slope reduction osteotomies, there's actually 3 different types or different techniques available. One is the supratuberosital osteotomy. Second is the osteotomy which is combined with the temporary removal of the tibial tuberosity, as shown in the right image. It's somehow used as a biological plate afterwards. And our preferred technique, which is probably the most common in Germany right now, is the infra or subtuberosital osteotomy. And I just want to show you or share some videos on that technique with you. This is just to demonstrate the technique using a sow-bone. You're basically doing a closed wedge osteotomy, leaving the tibial tuberosity in place and not affecting the insertion of the ligamentum patella, as shown in this sow-bone. And here is a sequence from our OR, patient with a significant AP translation with the rupture of the ACL after initial reconstruction. Posterior tibial slope is significantly increased. We use a medial parapatellar incision in order to expose the tibial tuberosity. It's really important to place hooks beneath the anterior tibialis anterior muscle on the lateral side and beneath the medial collateral ligament on the medial side. And afterwards, we use radiographs intraoperatively in order to determine the exact entrance point for your osteotomy, aiming on a spot which is just proximal to the tibial insertion of the PCL, leaving the PCL being a hinge actually on the posterior parts of the osteotomy. This osteotomy requires, as any other osteotomy, a preoperative planing, so you more or less calculate the height of your wedge, and afterwards you perform this saw cut. To be honest, I have not experienced any posterior hinge fractures, so the tibia seems to be really flexible in these posterior aspects, and once you remove this wedge, you actually just close the gap by extending the knee joint and putting some pressure on the tibial tuberositas. We usually use some K-wires in order to achieve a temporarily fixation, and afterwards, and this is something I don't feel 100% comfortable with, we use a conventional HTO plate at the moment, but this is something open to discussion, and I'm really looking forward that there might be some individual or more specific plates being available in order to stabilize this kind of osteotomy. One of my concerns in this technique is once the patient experiences or presents with a prior hyperextension prior to that osteotomy, because every slope change influences the range of motion. And once you have a patient with a pre-existing hyperextension of 5 or 10 degrees, and you add another 7 or 8 degrees slope reduction, this definitely will end up in a significant hyperextension, which is definitely a problem in my personal opinion. There is a study on that, on outcome, including postoperative range of motion by Ralf Koto from Hamburg in Germany. He actually describes that this does not seem to be a significant problem, but at the end, you should at least consider this a potential problem. How are we dealing with tibial slope in our daily practice or in my personal practice? As I mentioned before, we are evaluating posterior slope in every ACL case. We are also informing the patient with the primary increased tibial slope, even in the primary case, that this is a potential risk factor for failure. I have not shown these studies, but there is some literature available that probably anterolateral augmentation is also beneficial in order to be able to somehow compensate an increased lateral slope. This is our concept in primary cases. And in revision cases, we are really more strict in terms of correction of this bony deformity. And our present cutoff is 12 degrees. But this is something which I assume to be changed over time, and probably we will even get more aggressive in order to address this bony deformity. So thank you really much for giving me the chance to talk about that exciting topic.
Thank you, Philipp. We have a lot of questions about the anteromedial instability for you, Philipp, and when do you decide to do an extra procedure in the medial side, and how?
Yeah, I actually have only mentioned on one slide, but it seems to be a really hot topic. And this topic became really popular in Germany recently because there was some studies from England and also from my colleague Mirko Herbert here at the OCM in Munich, who actually demonstrated that the MCL is a more complex structure. We have this deep MCL, which we also call anteromedial ligament, because we are really aware that it influences the rotational instability. And since we have these studies available, we are really looking closer on medial instabilities. And I'm personally 100% convinced that an overseeing medial instability is a risk factor for ACL failure. And in these cases, we distinguish between these rotational instabilities and the pure medial instabilities. And this also affects how we deal with these instabilities. And we actually are fans of these flat MCL reconstruction in these rotational cases. So in these cases, we actually reconstruct these deep anteromedial fibers using a flat semitendinosus tendon. But this is something which has been changed just within the last 2 or 3 years in our practice.
Great. Question for both of you, maybe 1 or 2 questions quickly. There's a question, slope correction first and ACL revision in one stage? Yes, no doubt.
We actually started doing it staged because we did not really have a lot of experience with this kind of osteotomies. But now, since we are becoming more and more comfortable, I'm absolutely convinced that you can also do it one staged.
Sure.
Yes, also in one stage, we can fix with 2 staples. So you have the place to do your ACL tibial tunnel, so no problem for one stage.
Okay, there is one question for me. What is the limit of your procedure, ITB revision? You have to understand that, and you will see that in Toulouse during the next PCO Congress. In fact, we don't have any limit in Toulouse. We can do everything at one time and very easily, so please join us. Let me introduce the concept of the course in few words. This is a new concept made about the way of the transmission of the education. We will have virtual fellowship. We will discover the real life of the colleague. You will have the discussion about real cases and the classic setup about courses. Don't forget that Toulouse is probably the most beautiful city in the world, I think, Charles, you don't sure. And I would like once again to thank BIOBank for the support, particularly Patrick Joucla and Thierry Scandola. Really, I appreciate your support since the beginning of my career. Thank you very much for everything.